welcome everyone to a quick conversation with Dr. Michael Breen. He has been a diagnostic radiologist for more than 25 years, and today he and I are going to be discussing teleradiology, his experiences in it, and where he thinks it's going. My name is Dr. Pamela Ograbisz. I am a cardiothoracic nurse practitioner and the Vice President of Clinical Operations here at locumtenens.com, a Jackson Health company. So, Dr. Breen, we're going to jump right in. Tell me a little bit about your background. How did you wind up in medicine?
You know, my father is a retired surgeon, and I always wanted to be a doctor. His work seemed interesting to me. And as I got older, I thought, you know, I really like to learn. I love to learn. The more there is to learn, the better I like it. And so I thought medicine would be the perfect vehicle, the perfect job for somebody like me who's naturally curious. I'm curious about everything, and there's never too much to learn. There's always more to learn. It's amazing.
Mm-hmm. I agree. I agree. So you've had quite the career. Tell me, I know that you started out, right, as most of us did. There really wasn't a whole lot of tele options. I've been out of school a long time too. And when I first started, right, you reported to the hospital every day and you scrubbed in or did your rounds, and there really were no video visits. Can you tell me a little bit about the path that you took to get into the advent of teleradiology?
It was abrupt, and I have COVID to thank because the technology, when I started, years ago, I was able to look at images on screen, but it took about 3 or 4 minutes to get a single image. So it was just not practical from the kinds of volume that we do today. I was in the hospital working a hospital job, and COVID showed up, and I said, you know, by that time, the technology had arrived to the point where it was now feasible to do good quality radiology from home. And
Mhm.
once COVID hit, I said, hey guys, you know, I'm worried about like my longevity here. Is it okay if I work from home? And they said, that's a good idea. That's a good idea. I had the equipment and I never went back to the hospital.
So you've been working full-time remote for at least 3+ years?
2019 COVID pandemic was my release from the hospital forever.
Wow. Okay. And you're working full-time.
Oh, I'm working very full time. I'm probably working more than full time. Yeah, there's as much as I can possibly want to do. And the nice thing about working for locum tenens is I can say, this week I can work, this week I can't. This vacation I want off, this vacation I'm willing to work. You know, we have a good give and take. I have a great client. We work well together, and I try really hard to bend over backwards to be a good team player. And they let me do my job. They just let me do my job. I get very few little negative feedback. I just say, just keep doing what you're doing, and when are your next shifts available?
Well, that's great. So, a question for you, and I find this as well. Whenever I work remotely, I actually find myself to be a bit more productive. I'm not in radiology, but when I see patients, right, and I'm in rounds, I have folks that are moving my screen for me, and I find a little bit more productive because there's nobody interrupting me, right? I stay very task oriented. We move from patient to patient to patient. Do you find that you're actually more productive in your home?
There's absolutely no question. I'm far more productive because, like you said, it's the interruptions that really take a long time. And, you know, when you have somebody watching your RVUs, those interruptions really don't count for anything. You know, people want to come and look at films, and then they want to chat to you too, ask you about where you went to vacation. I mean, and then your colleagues, same thing with them. Sometimes it's, you know, I miss the colleague to colleague interaction, but from a productivity standpoint, there's no question I'm far more productive at home. And not only am I more productive, but I can do so with my temperature set the right way,
Mhm.
that my library's right here, the lighting is to my liking, I have my own refrigerator here. It just, and so I don't have to worry about going to the cafeteria to get something to drink or, you know, stepping outside to get a break. It's all right here.
Yeah, and you can work at your own pace and your own speed I think I've had some questions where people say, "Well, there's no way that they can read super complex scans on their basic computer." So, let's talk a little bit about equipment. I know that we, as a company, whenever we put a physician to work, we actually give the option to the client of providing the equipment. And depending upon the types of scans that they are reading, we provide very high level screens, right? 4K, 6K, 7K screens. So tell me a little bit about the equipment that you use. Do you use your own? Do you use equipment that's provided for you by a client? What does your setup look like?
So my computer is actually sent to me by locum tenens, and so are two of the three screens. The third
Mhm.
I purchased on my own. I have a three-screen display that's entirely suitable for reading. It's nice, it's tidy, it's plenty of room. In terms of the setup I had at the hospital, it's very similar. I had three
Okay.
screens at the hospital, the same exact size. I mean, at the hospital, I had barcode monitors. Here, I have ultra high definition screens that are commercially available. I mean, they're a little bit more, but they don't cost as much as a barcode. And there is never a time where I said, oh, I really wish I had higher resolution. Never. I mean, not like sometimes, but never, because I can magnify. It's not an issue.
Excellent. Good to hear that because I think sometimes that's pushback that we get, right? It's not the same as what you get when you're sitting inside of a radiology reading room. And I have heard the same from lots of docs that are reading at home, right? That they really do not see any kind of difference. You spoke a little bit earlier about the technology catching up during COVID and being able to read series of scans, right? In a much more in a quicker fashion. So when I'm assuming you're talking about MRIs and CT scans and the fact that they load much quicker, and now you can see those images faster. Um, can you talk a little bit about that? So, for maybe the folks that are considering moving out of a hospital grid and into the home, uh, you know, any concerns or worries there? What, do you feel like it is appropriate and that the technology is what you need it to be?
Right. So back in the day, it was significantly slower. And even when I started back in 2019, I could load my dishwasher before I had a couple thousand image case with olds for comparison. Now I don't have time to do much of anything. 3,000, 4,000, 5,000, even 6,000 images. It's just not really a time factor. And in fact, I can download one series while the others are downloading. It's not a major factor in the utilization of my time,
Excellent. Okay. What
even
about
compared to the hospital.
Yeah, oh, good. What about connections? Are you on Wi-Fi? Are you a hardwired connection? What do you use at home?
So I have two separate internet providers. I am hardwired. It's proprietary. The corporations don't really appreciate Wi-Fi because of security issues and HIPAA matters. So I have two separate internet connections. If one fails, which happens very rarely, then I have the other one because my clients count on me to be there and they don't want to hear about something about, oh, they're doing a downtime at Spectrum or whatever. So, yeah, Wi-Fi. And I don't even have the fastest, but I have done multiple speed tests with IT, and my connection is non-issue. In other words, the computer and the data coming over, it's more of a computer issue than it is for a connection issue. So it's just a non-issue.
Excellent. Sometimes I hear pushback that if you are reading at home, right, you're sort of doing so in a silo. You don't have other colleagues to bounce ideas off of or to say, "Hey, could you look at this?" How do you deal with those when, those naysayers that say, this is a problem?
Well, it's interesting because for quite some time now, more than 10 years, I've been working the night shift, and lots of times there's not much help around during the night shift. However, during the evening shift, have had just such a situation where I've said, boy, I wish I had a second opinion. Or my colleagues had said, boy, I wish I had a second opinion. So they call me up and they say, hey, could you look at a case on Sally Smith? I'm wondering about this thing I see right here below the xiphoid. And I'll take a look at it and I say, well, if you look at image 273, you see right here, I think there's a crescent of air. So I think that's a clue. We definitely collaborate over the phone. Then nobody has problems in understanding what I'm talking about. We go to series numbers and image numbers, and then I say, okay, take a look at L4, for example. Now, if you look just anterior to the right of L4, you see, and then the conversation starts. So it's really, I mean, other than pointing my finger, it's not
Hmm.
right in the hospital in the reading room with another guy.
Excellent. And what would you say, has there been impact on residents? So in other words, many times, right, residents are coming through their training, they're, absorbing all of the knowledge that you have as a senior physician. So has that impacted how residents are trained? Do you feel that residency programs and MDs, as well as honestly APP students, can be trained effectively with a teleradiologist?
The, the impediment that I experience is that when you have somebody new to imaging, it's more difficult to describe your way around the case.
Mm,
And so I have to use very rudimentary terms, and sometimes I may or may not be sure that they're actually seeing what I'm simply trying to describe. I can't point with my finger, I can't point with the mouse arrow, I can't point. Now, once I can point, then, just same as being shoulder to shoulder. This is what's going on. If you look right here, then you see this. If you measure it, then you see this. Look at the density measurements, etc. If I can't do that over my teleradiology yet, I can't show them. Okay, look, if you look right here, take a look at this image, and I can shake my arrow and point to it and flash the arrow. No, I can't do that. So I have to describe. So I find that resident physicians, they benefit more from actually being able to point to something in great detail. Magnify and point, for example, I can't do that for them. So that's a negative.
so there's a software limitation. We need to let PACS know that they need to get working on that. So
That would be a great asset for sure, no
yeah,
question.
I
Even
agree.
fellow radiologists or ER doctors love to learn, and they love it when you can tell them something, but that's not their strong suit. So
Right.
if you could point to something, and they learn, they appreciate learning, they appreciate you taking the time to teach them. So that would be something that, yeah, that would definitely be an upgrade.
Excellent. That's a really good point. Something that we need to carry forward from this conversation. So tell us a little bit about maybe your daily schedule. Do you cover just one hospital? Do you cover multiple hospitals? What does that look like? And is that hard?
Okay, so I have two different jobs.
Okay, let's talk
Yeah,
about both.
sure. So I have my day job, which is overnight, and my day job is I contract directly with a group, and I work 18 weeks a year whenever they want. I have a little bit of control, but I have other guys that also want, for example, July 4th off, etc. And we cover 2 inpatient hospitals and about 7 standalone ERs.
Okay.
My other job is a large community-based medical center in Toms River, New Jersey, and it's all inpatient, one hospital, over 700 beds, and it's busy. Things come from every direction. But the units, especially the ER, it's stick and move. It's busy, and the I work either from 8 to 5 or from 1 to 10 for them, and then I choose my weeks that I'm available for them. I try to give them some weekend days. I work July 4th for them, because like I say, we have a good working relationship. I help them, they help me. It's a temporary job, but it's been temporary for a year and a half. So
Yeah.
yeah, and I don't really predict they're going to be interested in letting me go until I get for a permanent guy anytime soon, because they're happy with my work and I'm happy working for them. So
Right.
it's,
Well, and
it's
as we know, there's a massive physician shortage in every specialty line. So I think when facilities are able to find highly experienced physicians that they are able to plug in on a known basis, right? And they get to know you, you really become a part of their staff. And so you're a part of their staffing plan. Doesn't really matter that you could be a 1099, right, or a permanent, as long as the work that you're doing is good for them and results in good patient outcomes.
Well, that brings up a very important point, because radiologists are kind of like any other relationship where both parties hope to benefit. And the fact that I don't live in New Jersey and don't plan to live in New Jersey or in Gainesville, but it's a good fit from an academic, from a service care situation, then those boundaries no longer exist. Where before you had to say, "Hey, honey, you want to move to Jersey? How about Florida? How about Minnesota?" I mean, you had to go there. Even when I moved to Florida back in 12, they wanted me 30 minutes from the hospital. Now I can work anywhere, and the value to that is that I can find the perfect fit for my skill set without having to leave the comfort of my home.
Right, which is great. And you're also bringing all of that amazing experience, which is what I find too, right? We really specialize in placing highly valued, highly experienced physicians all over the country. And that's the beauty of tele, right? The fact that you can marry those folks up and but they can stay where they're comfortable. And so you can be, you could live in Florida and work in California, right? It's really the best of both worlds. So obviously you enjoy the option. How many of your colleagues now work 100% remote?
At least five I can think of just without even trying, and that's
Hmm.
just because I don't. And some people have more of a hybrid schedule, but remote is the way of the future. It really is.
For
And
sure.
because the impediments, that the barriers that used to prevent quality care from a remote platform are rapidly deteriorating to the point where they just don't really even matter anymore.
Could you address some of those challenges for the naysayers in the room?
Well, I mean, here's one. I mean, you say, well, I can't go into a radiologist office and ask him about my case. And they might say, well, I miss being able to go into the radiologist office, picking his brain, going over some case, some future plans for imaging or kind of a game plan. I think they're not particularly happy with that. However, on the upside is the amount of work that I have, it's hard to keep up. The harder I work, the more cases seem to come. And so those sorts of things, that old fashioned way of doing things is rapidly deteriorating because just the volume, I mean, the ER is they're expecting turnaround.
Hmm.
They've got their own waiting room full of people. And so being able to kibitz with somebody about the nuance of the biopsy approach is it's just not good utilization of time. And so we leave that to the interventional guys and they do that sort of thing. And I just continue to carry on and provide the best service I know how to provide.
Absolutely. Let's touch a little bit. You had mentioned RVUs, right? Which is how folks in radiology get paid. Can you talk a little bit about has there been any impact on the fact that you read remotely and then the RVUs that you're billing for?
That's an excellent point because I dislike RVUs. I think it's a vehicle for sloppy radiology work because then it just becomes just working
For
for
volume?
the more you can read, and it doesn't really make the quality just falls by the wayside. So the benefit of working remotely is I'm paid by the hour. Now that's a double-edged sword because if I take advantage of that, I'll get paid the same, but my contract is going to end quickly. I mean,
Right.
they're not fools. However, I stay diligent. I give my cases the time each one deserves. Some are quick, some are not so quick. Some require comparison with holds or even remote holds. Those things are important in patient care, but you just don't have that sort of time when you're cranking out the RVUs.
Hmm.
You know, I've seen people, make recommendations for biopsies when 5 years ago was the same nodule. So, working through RVUs, and I understand why payers do it because people are lazy by nature, and so people just as soon not work. But my motivation is I have a good job, I'm happy with my job, They're happy with me. I don't wanna take advantage of the hourly pay over the RVU pay
Mm-hmm.
to to um to create an issue. I just want them to continue to be happy because I'll work for them until I can't.
So, well, and I agree with that. I think that the right quality over quantity is always important. And I do think the RVU system is a bit flawed in the way that it can be rewarded. So I think that you've said, right, the future is 100% teleradiology. We know that there could certainly be a few more improvements, primarily like with being able to point and show, right, in order to be able to teach. Any other things that you'd like to see come along in your field that would make things better or easier?
Well, actually, it's already here, and that's AI. And there has been a great gnashing of teeth over AI. Oh, AI is going to take our jobs. AI is going to take our jobs. But when AI points out a subtle bleed or a dot of free air or a small pulmonary embolism, it's back up for me. It makes me faster, more accurate, and it's only going to get better. I mean, sometimes it gets things wrong. That's what
Right.
I'm here for. That's my value added. But searching for a 3 millimeter nodule is not optimal utilization of my time.
So is that, how is it being plugged in now? Does it run in the background of the scan that you pull up and then you're able to look at it and say, yes, I think that's something I would like to look into more or something I'm going to ignore?
it runs in the background, and then when it makes what it thinks is a significant finding, and it's right more often than it's wrong, it says, "Hey, this looks like a rib fracture," and you look at it, and you're like, sure enough is. That's an
Hmm.
acute rib fracture. And you're like, well, thank you very much. You just saved me a lot of time searching for a rib fracture. And then it says, oh, here's a vertebral body compression fracture. And I'm like, it's the same as it was 10 years ago, but thank you for your opinion. So I can pick and choose, but it points you right there like it's a backup.
Yeah,
It's really nice to have. So that future is in progress.
very, very good. So you're in favor, right? Because you're like, it's an additional tool for support.
Well, not only am I in favor, but the fact of the matter is, whether I am or not, it's coming.
Yeah,
You know, doesn't my and we could stand around little signs in our little white lab coats, no AI or something like that. It's not natural, but it's coming, and quite frankly, with the volume that the way the volume is going, it's a godsend. Because it helps to prioritize patients. I mean, sometimes it's wrong,
hmm,
but it just speeds up my work. It's like having another radiologist here, like, hey, what about this? Hey, what about that? And more often than not, with some of the pulmonary nodules, it's a little bit of it's cumbersome. It's not particularly helpful. But a lot of the other things, brain bleeds, free intra-abdominal air, pulmonary embolism, aneurysms, it's really good, and it's only going to get better. And radiologists are going to get smarter. ER doctors are going to get earlier notification that, hey, and they know what a bleed looks like. They know a lot. So, it's all good. It's only getting better.
that's excellent to hear. So if you had to leave the audience with one last tidbit, one last pearl about teleradiology, what would that be?
Do it. Just do it.
Just do it. I like that. We're gonna steal it from Nike. So I would agree. I think that right, the more access that we can give to hospitals and patients, that's what this does. It broadens the access.
Well, it not only broadens the access, but it could broaden the access to, super specialists. I mean, when you have a specialist that doesn't live where you are and you want some, top of the line expert opinion, maybe somebody who specializes in that field, they're available now. Whereas heretofore they'd have to drive or fly or, get them, or you'd have to send them a disc. Now it just plug in.
Absolutely. Yeah, it's really been, I think probably right, the silver lining of COVID was the expansion of a lot of the laws and the red tape that was surrounding tele, period. So it's really nice to see where it's gone and hopefully where it will continue to go. I think there's a good bit of bipartisan support for it, in the legislative rooms up in DC. And so we certainly hope that the DEA continues to bolster those laws, enable prescribing, but also enable parity and good payership for the work that you're doing, because just because you're doing it across a screen doesn't make it any less medicine. And I think that sometimes there is a pushback there saying, well, because the screen is in between you, or that's how you're doing the bulk of your work, that it changes it. And for that, obviously this conversation has shown you can be 100% of the same as if you were sitting in a radiology reading room at a hospital.
Actually better, because I'm faster, I spend less time commuting, I'm sharper. It's a great way to do medicine.
That's fantastic. Well, I can't thank you enough for your time today, all of your expertise. I know that your patients benefit from you every single day. So thank you for all that you do. And I appreciate the audience joining us.
Thank you, Dr. Pam.
Thanks, Dr. Breen. Appreciate you.